All right, hello friends, moving on with our discussion further. Let's begin with question number 54 here. Now the question says timing hypothesis is based on the fact that if women are given postmenopausal therapy, hormone therapy, that is estrogen administration, it reduces the incidence of which of the following diseases. Now if you see, HRT is protective for osteoporosis. HRT is also protective against Alzheimer's disease, is thought to be protective. This is plus minus whether HRT is protective against Alzheimer's or no. But this timing hypothesis specifically refers to coronary artery disease. What it meant was that it was suggested that HRT, right, HRT, especially estrogen containing HRT, when it was given to women who were younger, okay, HRT which was given to women who were younger, specifically less than 60 years old, it was seen that it did not increase the risk of coronary artery disease. In fact, when given, in women who had just started their menopause, like 45, 50s, all right, then it was thought to be protective. In fact, it was thought to be protective when the initiation was earlier. Protective when the initiation was earlier. Example, immediately after, immediately after the onset of menopause, like example, if it was given to women in their 50s, immediately after initiation of their menopause, then this HRT has been seen to have a protective role as far as coronary artery disease is concerned. All right. So, in a nutshell, to simplify, HRT as in a nutshell, to simplify, HRT causing heart disease or leading to risk of heart disease or coronary artery disease, to be very precise, the risk is more if the HRT is initiated in women who have considerably, like let's say, who are considerably advanced in the menopausal age. So in a nutshell, HRT increases the risk of coronary artery disease if it is given to women more than 60 years of age. All right. So we see that HRT on one hand increases the risk of coronary artery disease when it is given to women more than 60 years of age, and when given to women younger than 60 years of age, it does not specifically increase the disease. In fact, it was thought to be protective when initiation was earlier. That is why this is what is called as the timing hypothesis. HRT on the other hand also increases the risk of invasive breast cancer. This is very, very important to remember. HRT increases the risk of invasive breast cancer, especially if it is estrogen plus progesterone, then not estrogen alone. All right, this is one important point. And another important point to remember is that HRT is protective. HRT is protective, definitely protective for, I can write it here, sorry, HRT is protective. Another important point to remember is that HRT is protective for two things. One is osteoporosis and the other is colorectal cancer. Rest, HRT being protective for Alzheimer's and Parkinson's, all these are plus minus situations. All right, so they are not definitely protective for those conditions, but HRT is definitely protective for osteoporosis and colorectal cancer. Now moving on to the next question. Breastfeeding can be encouraged despite which of the following conditions? Now this is an often repeated question. Let us see what the options here are. Maternal hepatitis B, maternal reduction mammoplasty. See, it is clear if we go option by options. In maternal reduction mammoplasty, breastfeeding is just not possible, all right? In acute puerperal mastitis and maternal treatment with lithium carbonate. So these two options are absolutely excluded, where we will not go for breastfeeding. Concerning maternal hepatitis B and maternal acute puerperal mastitis, in both these situations, all right, in both these situations, breastfeeding is not contraindicated. But remember, a better answer would be in this situation here would be maternal acute puerperal mastitis, where breastfeeding is continued even on the affected breast. All right, maternal hepatitis B is no longer a contraindication for breastfeeding. All right, maternal hepatitis B is no longer a contraindication of breastfeeding. In fact, whenever the mother has hepatitis B infection, we give immunoglobulin and vaccination to the newborn. All right, so maternal hepatitis B is no longer a contraindication, but among these four options, C is the better answer. Ideally, in this situation, both answers should be correct, but I have to choose one. C is the better answer. So therefore, I go with option number C. However, such questions where no longer would maternal hepatitis B be clubbed, should be clubbed with maternal acute puerperal mastitis, just to create confusion. But anyhow, the takeaway points from this question is that in maternal acute puerperal mastitis, breastfeeding is continued even on the affected breast, and in maternal hepatitis B, breastfeeding is not contraindicated. But if I have to choose in such a situation between these two options, I will choose C. Question number 56 has already been discussed, so we will not go ahead with this. Let us move on to the next question, question number 57. Now, the most common presenting feature of Asherman syndrome is, answer is B, that is hypomenorrhea. Now, just to summarize, what are the important features of Asherman syndrome that you should remember, because Asherman syndrome is an important cause. Asherman syndrome is an important cause of infertility. It is an important cause of menstrual disturbances. All right. Now, why does it cause infertility? It is responsible for infertility because obviously the endometrium is replaced by adhesions, right? And so if there are adhesions, obviously there is no implantation happening. And again, menstrual disturbances are also because of adhesions, because the endometrium is destroyed, and that is why there is no more endometrium which is developing. It is all replaced by dense fibrous adhesions, and that is why the menstrual disturbances also correlate with the type of pathology, that is adhesions, and then it is called as hypomenorrhea or amenorrhea. These are the menstrual symptoms which happen with Asherman syndrome. Now, the important point to remember about Asherman syndrome, that the risk factor of Asherman syndrome is multiple DNCs, multiple curatages on the endometrium, multiple scratching curatages of the endometrium for whichever indication are responsible for developing Asherman syndrome. And importantly, this DNC, especially if done postpartum, Now, why is it like that? Especially if done postpartum. Why? Because in postpartum state, what happens is that the decidua right? The placenta separates from the decidua spinosa level or the spongiosa level, and what is left behind is the decidua basalis, right? So what is important to remember is that not all curatages do lead to development of adhesions or Asherman syndrome. It is those curatages where the decidua basalis is destroyed. It is those curatages where the decidua basalis is destroyed that Asherman syndrome results. All right, that Asherman syndrome results because decidua basalis, this basalis layer of endometrium, right? This basalis layer of the endometrium is the one that is responsible for endometrial regeneration, right? So obviously, if we have if we have destroyed the decidua basalis, then it leads to Asherman syndrome, and that is why postpartum curatages specifically can lead to Asherman syndrome. Another risk factor in our country, the first is multiple DNCs. Another risk factor is endometrial tuberculosis. That also leads to Asherman syndrome, right? Now, tuberculosis, endometrial tuberculosis in the acute stage, when endometrial tuberculosis results, it leads to just endometritis, right? And this endometritis can cause menorrhagia. So, menorrhagia becomes the first menstrual symptom. This becomes the first menstrual symptom with genital endometrial tuberculosis. This becomes the first symptom. However, endometrial tuberculosis ultimately will lead to the chronic stage, and in the chronic stage it will lead to adhesions, and once adhesions will come, it will lead to hypomenorrhea or amenorrhea, which becomes the most common complaint with endometrial tuberculosis. So endometrial tuberculosis, when in the acute stage, leads to endometritis, menorrhagia becoming the first symptom. However, if you are asked what is the most common, not complication, sorry, most common symptom as far as endometrial tuberculosis is concerned, it is hypomenorrhea and amenorrhea, because in the chronic stage, it leads to adhesions. All right. Now, Asherman syndrome, how it can be diagnosed. All right. Now, the diagnosis of Asherman syndrome, the investigation of choice of a diagnosis, it is hysteroscopy. All right, it is hysteroscopy. HSG on the other hand, hysterosalpingography on the other hand, is only screening. All right, it is only screening. So if we are investigating, let's say, an infertile woman, right, and we are investigating her, and in the process of investigation we have done HSG for tubal factors, right, then we might find features suggestive of Asherman's, right, which is multiple filling defects, all right. So this is the usual way where Asherman syndrome is picked up. Like in infertile women, during investigation, HSG is done for tubal factors, then Asherman is picked up because of filling defects. Therefore, HSG is only a screening for Asherman's, okay? It does not make the diagnosis. The diagnosis is made by hysteroscopy, and hysteroscopy is better. Why? Because for the treatment purposes there is hysteroscopic adhesiolysis. So in the same sitting we can do hysteroscopic diagnosis as well as hysteroscopic adhesiolysis, and following this hysteroscopic adhesiolysis, what is done? Intrauterine device insertion and high dose estrogen. High dose estrogen is given in the form of oral contraceptive pills for 3 to 6 months, and this is done to build up endometrium, to build up the endometrium. This is done, and IUD insertion is done so that after removing the adhesions, the uterine walls can be kept apart, because if again after the separating the incisions, after adhesiolysis, if the uterine walls collapse onto one another, again adhesions will form. So this is usually done for the Asherman's syndrome. All right. Now, moving on to the next question, question number 58. All are true regarding the below procedure. First of all, the below procedure is what is happening. This is the blastomere, from which one blastomere is being sucked out into the pipette. This is the zona pellucida, and we should remember that zona pellucida surrounds the developing embryo till the blastocyst stage. All right, the zona pellucida, this surrounds the embryo, till the blastocyst stage, and once the blastocyst develops on day 5, zona hatching occurs. Okay, zona hatching occurs just before implantation. Okay. So this we have done. So that is why it is important in this figure to remember that this is the zona pellucida, and as we can see clearly there is only blastomeres. This is not a blastocyst, so this is a morula stage, and what is happening is the blastomere sampling is being done. Now in a blastomere is representative of the embryo, so only maternal genes can be tested is the false statement here. Zona pellucida is pierced, this is the true statement. If you move further, such procedure can only be done if IVF has been done, obviously, because not until the embryo is in the petri dish can we do this test. So obviously embryo is outside the body, so it is always accompanied by IVF. This is also true, and one cell is typically removed. This is also the true statement. So this method, why is it employed? This method, this blastomere sampling, is a method of pre-implantation genetic diagnosis. It is called as pre-implantation genetic diagnosis, which is PIGD. All right. With pre-implantation genetic diagnosis, we want to diagnose for any single gene disorders, any genetic chromosomal abnormalities. We can diagnose for a number of things in the embryo itself. Therefore IVF is done along with this pre-implantation genetic diagnosis. And another important point is what can be the samples, as far as this is very, very important point to remember. What can be the samples as far as PIGD is concerned? The samples can be blastomere biopsy, right? So blastomere biopsy can be sampling, can be done like we saw in this figure. The second type of sample could be a trophoectoderm sampling. Trophoectoderm sampling, where we sample at the blastocyst stage. This we do at the blastocyst stage, and we are sampling the trophoectoderm. In blastomere biopsy, we are sampling a day 3 embryo in the morula stage, and we are removing one blastomere. So this is done a little earlier. This is done in the blastocyst around day 5 embryo. This is done. And the third sample that can be taken is the polar bodies, right? Now there are a specific set of advantages, disadvantages. Very importantly, with polar bodies, the disadvantage is that only maternal genes can be tested. All right. So if we want to test for paternal genes, then this is not possible. Only maternal genes can be tested. This is the problem with polar bodies. With trophoectoderm sampling, you have to remember that the trophoectoderm develops into the placenta, right? So sometimes if you are testing for a chromosomal analysis of the sample from the trophoectoderm, it might not be representative of the embryo. So the problem with this trophoectoderm sampling is sometimes the abnormality in karyotype may be confined to placenta only, and may not be representative of the embryo. This problem is called as confined placental mosaicism, confined placental mosaicism. So this is a problem with trophectoderm sampling. And blastomere biopsy is also possible in day 3 of the morula stage. With blastomere biopsy, we are biopsying the part that ultimately develops into the embryo. So this confined placental mosaicism is not a problem with blastomere biopsy. So with pre-implantation genetic diagnosis, we should at least remember these important points, that the samples can be blastomere, can be trophoectoderm, or could be the polar bodies. Now let us move on to the next question. Question number 59. We have already discussed this question, so we will not go into the discussion with this. The correct answer is option number D. Moving on to question number 60 regarding bone mineralization, which is the correct treatment for a woman with osteoporosis and no problems of hot flushes. It has to be remembered, for osteoporosis the treatment is bisphosphonates, right? So here you have to remember that bisphosphonates are equally effective as estrogen in bone formation. There is no role of progestin therapy. Estrogen plus progesterone, no. Progesterone therapy, no. So for osteoporosis, we've already discussed the treatment of choice is bisphosphonates. Question number 61 has also been already discussed. The correct answer here is B, if we have failed to tick in the previous discussions, but we've already discussed this question. Let us see question number 62. MTP cannot be done after. Now the answer here is 20 weeks. We have to be very certain. We have to be, MTP again is very, very important, and MTP, a part of MTP you do even in your PSM lectures and everything. But you have to remember about MTP is medical termination of pregnancy by the government of India is allowed only till 20 weeks, all right, till 20 weeks. In the first 12 weeks, only one registered medical practitioner's signature are enough, okay? So only one registered medical practitioner is enough to consent or is enough to approve or consider that the MTP is justified, all right? But if it is between 12 to 20 weeks, then 2 RMPs are needed to justify the performance of MTP in a particular woman, all right? So bottom line, period, 20 weeks and beyond, there is no MTP which is allowed by the government of India. First 12 weeks, one person, one obstetrician, one registered medical practitioner is enough to conclude that abortion is justified. Between 12 to 20 weeks, 2 registered medical practitioners are needed to justify performance of an abortion. Very, very important point. Second important point to remember about MTP here, I would again give you, is that the consent of the spouse is not mandatory. So if a woman comes requesting for MTP and she is more than 18 years of age and she can give a valid consent, that is all that is required. Consent of spouse is not mandatory. Another important thing I want you to remember is about the medical abortion. Why medical abortion? I mean the abortion which is given by Mife plus misoprostol. And please clearly remember that the Ministry of Health and Family Welfare allows medical abortion by mifepristol and misoprostol only till 7 weeks. However, our WHO and the ACOG, they say that it is safe up till 9 weeks, all right? So depending upon if you are asking false or true statements or whatever, both of these are statements are important to remember. If they ask you that medical abortion can be done till, a blanket question like this, it can be done till 7 weeks as far as the Ministry of Health and Family Welfare guidelines are considered. But you also should remember that medical abortion given up to 9 weeks is also safe, because the WHO and ACOG says that that is also safe enough. But for recommendation purposes, it is recommended only till 7 weeks. Moving on to the next question. 63 question has already been discussed, so we will not discuss this question again. Partograph I have discussed in detail with you. Let's move on to the next question. Question number 64 has also been discussed in detail when talking about ectopic pregnancy, so we move ahead. 65 here. Now question number 65 here. See, now figure based, now vaginal infections, right? Vaginal infections, particularly your Candida, Trichomonas and Bacterial Vaginosis, these three are very important vaginal infections. Clinical based questions can be asked on these questions. Similarly, like you have got this figure based question here based on Bacterial Vaginosis in this scenario, such questions can be asked. So be sure that you at least see what the slide, this is a pap smear, this is a gram stain slide that is being done here. It could be a wet smear also. What we see here is this vaginal cell and dot 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 like structures on the top. These are clue cells. So this is clue cells, which is characteristic of bacterial vaginosis, right? So we know that we are dealing with a slide of or a patient of bacterial vaginosis here in this question. Also remember that if a slide like this was made of the vaginal discharge and we were to see pseudo hyphae or we were to see a flagellated organism, so you should know how these organisms will look on a wet smear. So that is again important. So in this question, let us read the question here. A 21-year-old girl is having vaginal discharge 1 week after unprotected sexual intercourse, right? So we realize here after another thing that unprotected sexual intercourse making the genital secretions more alkaline, right? So alkaline, that is why, you know, bacterial vaginosis is more common like after menses, all right, or after this after sexual activity or with multiple sexual partners. This becomes a common condition. These are the risk factors for bacterial vaginosis because they make the genital secretions alkaline. The smear of vaginal discharge is shown below, which I told you these are clue cells. All are diagnostic criteria for the condition shown. That means for bacterial vaginosis, what are the diagnostic criteria and what is not. So like I told you, the answer is vaginal pH. So vaginal pH in bacterial vaginosis is more than 4.5. This positive whiff test, clue cells and presence of Gardnerella, these are all features of bacterial vaginosis. Vaginal pH more less than 4.5 is the wrong statement here. In fact, vaginal pH is more than 4.5. Now let me give you just a flow chart to help you answer such type of questions. Let us talk about bacterial vaginosis. Okay, let me give you a few vaginosis. There is Candida, and there is trichomoniasis. All right, there is trichomoniasis. Now, first of all, remember important points I want to tell you, highlighted. STD, which among them is an STD, a sexually transmitted disorder? So, bacterial vaginosis is not a sexually transmitted disorder. Trichomoniasis, on the other hand, is an STD. Therefore, partner treatment is must in case of trichomoniasis. Candida is usually not a sexually transmitted disorder. All right, so partner treatment can be omitted in this case, but it has to be definitely given in case of trichomoniasis. What about the vaginal pH? What about the vaginal pH? The vaginal pH in case of bacterial vaginosis is more than 4.5. With Candida, it is less than 4.5, and the trichomoniasis, it is more than 4.5. The discharge characteristics: with vaginosis, it is a foul-smelling gray-white discharge, foul-smelling gray-white discharge. With Candida, on the other hand, it is a curdy, white, cheesy discharge. There is intense pruritus, and there is dysuria, and urinary symptoms are frequent. In trichomoniasis, apart from dysuria, the discharge is greenish in color, and there can be another finding with trichomoniasis is called as strawberry cervix or vagina, sometimes can be seen with trichomoniasis. If we talk about the wet smear with bacterial vaginosis shows clue cells. With candida, it can show pseudohyphae. With trichomoniasis, there is going to be a flagellated organism, which is Trichomonas vaginalis. Then VIF test. VIF test is also called as a mean test. It is also called as KOH test. Now this test is positive with vaginosis. With candida, it is negative. It is positive with trichomoniasis. Another important point, WBCs in discharge are negative, not present in vaginosis. They are positive in candidiasis and they are present in trichomoniasis. The treatment, as far as concerned, the treatment with vaginosis is metronidazole. The treatment of candida is fluconazole, and the treatment of trichomoniasis is again metronidazole. Now, important thing, if you remember this chart here, remember these four: vaginal pH, discharge, wet smear, and vaginal pH, discharge, wet smear, and VIF test. These four criteria together make up the Amsel's criteria. This Amsel's criteria is used for the diagnosis of bacterial vaginosis. 3 out of 4, if present, makes the diagnosis of bacterial vaginosis. So remember, pH, discharge, wet smear, VIF test. These 4 together make up the Amsel's criteria. So when we ask you, sometimes this question has been asked specifically, that what is the investigation of choice for bacterial vaginosis, then it is a wet smear. And when they ask what is the gold standard for the diagnosis of bacterial vaginosis, so in wet smear we are, so investigation of choice of bacterial vaginosis is wet smear, and the clinical criteria of which the wet smear is the part is called the Amsel's criteria, and the gold standard for bacterial vaginosis is Nugent scoring. In Nugent scoring, we are actually staining the discharge prepared on the slide with gram staining is used, and gram staining is used, and we just count the number of gram positive versus gram negative rods. Lactobacillus is the gram positive rod. It is replaced by the gram negative rods, which are Gardnerella, Mobilingus, Ureaplasma, and all these, and that can be counted. And a Nugent score about 7 to 10 is diagnostic of score of 7 to 10 is diagnostic for bacterial vaginosis. So remember this much about bacterial vaginosis. Another important aspect is about bacterial vaginosis in pregnancy. Now, bacterial vaginosis in pregnancy is a risk factor for preterm labor. Right? It is a risk factor for preterm labor. However, in pregnancy, there is no routine screening for bacterial vaginosis. Right? If at all we were to find out asymptomatic bacterial vaginosis, it is not treated. It is only the symptomatic bacterial vaginosis which is treated in pregnancy. Alright, so it is a woman, if a woman is symptomatic with bacterial vaginosis, she is treated in pregnancy. If she is asymptomatic, she is not treated, and there is no routine screening for bacterial vaginosis in pregnancy. However, bacterial vaginosis in pregnancy is a risk factor for preterm labor. Remember these 4 important dot points about bacterial vaginosis in pregnancy. Now, moving on to the next question. Question number 66 here. A 70-year-old female patient present with recurrent dysuria. She's 70-year-old, there's recurrent dysuria, but urine routine and culture is negative, so there is no UTI. But urinary symptoms in a 70-year-old woman, it is because of the menopausal status, or the menopausal vaginal and urethral tissue dryness, which is responsible for this recurrent dysuria. So ideally here in this case, the treatment should have been local estrogen creams, but since that is not in the option, C is the option to be chosen, because local estrogen creams is not in the option. Otherwise, if that would have been the option, that would have been your treatment. But among this, hormone replacement therapy can be marked as the correct answer. Question number 67, what is the drug of choice for Trichomonas vaginalis? I right now told you it is metronidazole. All right, and this metronidazole is given in a dose of 2 grams single dose, okay, 2 grams single dose is used. All right. Moving on to the next question, HIV transmission in pregnancy is maximum during labor and delivery. We have discussed HIV in pregnancy in detail and taken the revision points along with that discussion, so we will move ahead. 69, highest rate of transmission of toxoplasmosis in pregnancy is in which trimester? Now the answer to this question is B, in the third trimester. Now I just want to highlight, see these topics again, infections in these toxoplasma, varicella zoster and all these. So these infections, you don't have to go into the in-depth explanation of these questions, but what is important to remember is a part of these infections are obviously always covered in your microbiology, right? And apart from that, we just want to remember the salient points about these infections in pregnancy. So talking about toxoplasmosis in pregnancy, let me give you a flow chart, or give you just the very, very important basic points which you should remember about toxoplasmosis in pregnancy. Now toxoplasmosis is a very ubiquitous kind of an infection. Almost most of us acquire this toxoplasmosis infection and get healed with it, but you have to remember that once a person is infected with toxoplasmosis, that person remains infected for life. And at any point of time there is any immunosuppression, then this virus can get activated and create problem. Right? So what happens is that if it in the immunocompetent individual, toxoplasmosis leads to no problem. But in an immunosuppressed individual, it can get activated and lead to problems. So importantly, you have to remember that if it is a chronic infection, a mother who has a chronic infection with toxoplasmosis, or I mean to say an old infection with toxoplasmosis, more than 1 year old infection with toxoplasmosis to be very precise, then it does not cause adverse effect in pregnancy. It does not cause, AE is any adverse effect in pregnancy. It does not harm the pregnancy. It is the acute infection, or let me just say that it is the infection which is recent infection in the past 6 months or so, which can cause adverse effect in pregnancy. Past 6 months meaning past 6 months from conception. Past 6 months from conception, then this is the infection which can cause adverse effect in pregnancy. Otherwise, any old infection is not going to harm the pregnancy. Now, how does this toxoplasmosis harm the pregnancy? It is responsible for first trimester abortions. It is responsible and for spontaneous abortions. Okay, for spontaneous abortions, it is responsible for fetal abnormalities. If fetus gets infected, it is responsible for fetal abnormalities like chorioretinitis, hydrocephalus, intracranial calcifications, and convulsions. Now this is the classic tetrad. This is the classic tetrad of toxoplasmosis infection in the fetus, that is chorioretinitis, hydrocephalus, intracranial calcifications and convulsions after the child is born, right? So how there is no specific treatment for toxoplasmosis. The only thing that we can do is treat the mother to prevent fetal infection, right? So what can we do to prevent fetal infection in a mother who has toxoplasmosis? To prevent fetal infection, if we suspect acute toxoplasmosis infection in the mother, then spiramycin is started immediately. Spiramycin is started immediately if acute toxoplasmosis is suspected in the mother, right? So spiramycin is started immediately, only even on the basis of suspicion alone with acute toxoplasmosis. Once the diagnosis is confirmed of acute toxoplasmosis in the mother, and how is this diagnosis confirmed? This diagnosis is confirmed by the rising titers of IgG that will confirm that it is actually an acute infection. So rising titers are going to confirm that it is an acute infection. So once the diagnosis is confirmed, we have to offer amniocentesis to detect fetal infection, and this we do beyond 18 weeks of gestation. If on amniocentesis fetal infection is also positive, we change to pyrimethamine and sulfadiazine. Pyrimethamine and sulfadiazine is given to the mother. If the fetal infection is negative, then we keep continuing spiramycin. All right. So important thing is spiramycin is for prevention of fetal infection. Important point, pyrimethamine plus sulfadiazine is for treatment of fetus. And to decrease the severity of fetal infection. So this is another important point, and another important point to remember is that another very important point which I did not tell you earlier about toxoplasmosis is that the risk of fetal infection increases with gestational age. That means that the risk is more in the third trimester as compared to second trimester as compared to first trimester. However, the risk of fetal infection increases with gestational age. However, the fetus which is affected in third trimester is usually a mild infection, and if a fetus get infected or affected in the first trimester, if earlier on in pregnancy, then the infection is more severe, right? So risk of fetal infection increases with gestational age, but the severity decreases. So the maximum chance of fetus getting affected are in the third trimester, but that is usually a milder infection. The earlier the fetus gets affected, the more severe the infection is. So this is about toxoplasmosis in pregnancy. In brief, this is at the most you should remember about toxoplasmosis. These are the important features as far as the obstetric part of toxoplasmosis is concerned. Now, Coming to the next question, question number 70. Now this question number 70 is talking about gestational diabetes mellitus and diabetes in pregnancy. Now I want you people to, because this is an important topic, especially in the sense that the clinical based questions like this question such questions are expected in AIIMS and PGI examinations, and then one-liners, direct one-liners have often been asked from this topic in your NEET based examination. So now for the next part I want to focus on question number 70, and the discussion will be of question number 78. These two questions pertaining to diabetes in pregnancy are going to be discussed. Question number 70, you can mark the answers here, B and C. We will come and discuss it one by one. Let us just talk about diabetes in pregnancy. Now very importantly, just few important points to remember about diabetes in pregnancy. You should understand that diabetes in pregnancy can be broadly of two types. One is the gestational diabetes. Now gestational diabetes, very important, is the diabetes which is first time diagnosed in pregnancy with no previous history. That is what is gestational diabetes, and it is usually, it happens in the 24 to 26 weeks, because that is when the insulin resistance is maximum, So this is what is gestational diabetes. It is for the first time diabetes diagnosed in pregnancy. It is usually within the 24 to 26 weeks, because insulin resistance is maximum during that period of time. Now any diabetes which is diagnosed in the first trimester, all right, any diabetes which is diagnosed in the first trimester is still labeled as gestational diabetes, because it is first diagnosed in pregnancy. But the important point is a diabetes which is diagnosed in the first trimester, diabetes which is diagnosed before 24 weeks, or let's say in the first trimester, is more likely to be overt. However, it is still labeled as gestational diabetes. Now what is overt diabetes? Overt diabetes is the diabetes in which the woman has been diabetic before pregnancy. So if she has been diabetic before pregnancy, or she is diabetic even in the first trimester, then what is happening, that in the periconceptional period, she is having deranged blood sugar levels, and therefore it is overt diabetes or type 2 diabetes mellitus, which is more common than the type 1. It is this overt diabetes where there is risk for congenital malformations in the baby, congenital malformations, GCAs, and the risk for abortions. All right, rest all other fetal complications can be seen in both overt diabetes and gestational diabetes, but with GDM, gestational diabetes mellitus, congenital malformations and abortions are not there. They are there with overt diabetes. So these complications, they are not seen with GDM, gestational diabetes mellitus, during which time, because it is usually coming in 24 to 26 weeks of pregnancy, right? Now talking about the various types of congenital malformations which are there. Talking about the congenital malformations, you should remember that the risk of congenital malformations in a normal pregnant woman is around 2.5%. Is around 2. The baseline risk of congenital malformations is about 2 to 3%. Excuse me. Is about 2 to 3%. Now this risk is doubled, that is becomes around 5% with diabetes mellitus, overt diabetes mellitus. And another important point you have to remember, that this risk is related to HbA1c levels, okay, directly related to HbA1c levels. So when the HbA1c levels are less than 8.5%, the risk of congenital malformations is 5%, okay, 5% risk. And when these HbA1c levels are beyond 10%, then the risk of congenital malformation becomes 4 times, all right. So about 9% is the risk, all right. So you should remember that HbA1c levels are very, very important when counseling a woman, when counseling a diabetic woman who gets pregnant. So important thing is, if a diabetic woman gets pregnant, if a diabetic woman attempts pregnancy, gets pregnant, or it is planning to conceive, then she should be counseled that her HbA1c levels should ideally be less than 6.5% to have better outcome for the fetus, or to have the low risk of congenital anomalies, to save the woman from congenital anomalies in the baby. So obviously you have to remember that this risk of congenital malformations is related to the HbA1c levels. Therefore, if a diabetic woman gets pregnant or is planning to conceive, HbA1c levels should be tested, euglycemia should be maintained, control of blood sugar should be achieved, and HbA1c level should ideally be less than 6.5%. Now, what are the congenital malformations we are talking about? The questions that are asked most of the times is, which is the most common gross congenital anomaly? Then the answer is CVS is more than neural tube defects. Among CVS, which is the most common CVS anomaly in a case of diabetic mother, then the answer is VSD. If they ask you which is the most specific anomaly overall, is sacral agenesis, which is also called as caudal regression syndrome, This is you have to remember. And another important point, if you have to remember, most common CVS finding in an infant of diabetic mother, then the answer to this question is hypertrophic cardiomyopathy. So these are the important points about the various type of congenital anomalies which can be found in the diabetic pregnancies. Now, another important aspect of diabetes is screening. All right, screening for diabetes. Now, first of all, you have to remember that in our country, in India, we have universal screening for diabetes in pregnancy. All right, so we screen all women, right? So all women are tested, and at what time? They are tested around 24 to 26 weeks, because that is the time that it is developed. Earlier testing, you should remember that earlier testing or testing in the first visit itself should be done if there are high risk factors like history of GDM in previous pregnancy, like strong family history of diabetes, like history of difficult delivery, history of macrosomia or bad obstetric history, or obesity, right? All these are risk factors where, or at any point in time, if there is glycosuria, these are risk factors when there should be earlier testing or testing in the first visit itself. Otherwise, universal screening is done at 24 to 26 weeks. If the woman has any of these high risk factors, then testing should not be left till 24 to 26 weeks. It should be done in the first visit itself or any time earlier. even if she presents in the first trimester itself. Now, whatever be the timing of testing, the tests that are done, what are the screening tests which are available for us? These screening tests are or sometimes they can be diagnostic also, in the sense that in which way these tests are employed. We can have the two-step test in which we use the GCT with 50 grams of glucose. This is glucose tolerance test with 50 grams. If 1 hour after this 50 gram load, if it is more than 140 gram per deciliter, then we do a confirmatory test with GTT, and this GTT has to be done with 100 gram, and then we have 4 values. We have fasting, 1 hour, 2 hour and 3 hour. I will not focus on this test right now because most of us have moved on to the one step method, where screening and diagnostic is just one step. There is no additional diagnostic test involved. So we have one is the WHO says that we give 75 gram glucose OGTT, and we do it irrespective of the fasting status. And if the 2 hour post this OGTT is 140 gram per deciliter, then it is GDM. Now, this is a very simplified method of diagnosing. Only one value is required. Woman need not be fasting. So this is one test that has been suggested. Now, the other test is done, which is given, usually followed in AIMS. Sometimes AIMS frames the question with these values, and this is also important. And this is very, very important, a must to remember, that in this also it is a 75 gram glucose OGTT which is done, but the difference from the WHO value is that it is a more stricter criteria, and we have fasting values. We have 75 gram, we do a fasting blood sugar, then we give the 75 gram oral glucose load, then test 1 hour and 2 hour. All right, so we have 3 values in this test. This is a very, very important test. The fasting, the cutoff is 92, 1 hour the cutoff is 180, and 2 hour it is 153, and this is the cutoff. If it is more than this, it is GDM, and in this case only one value needs to be abnormal to make the diagnosis of GDM. All right, so this is again very important. These are the values which should you remember: fasting 92, 1 hour 180, 2 hour 183. Very, very important values to remember. So whichever test you use, you either use one step, two step, any of these can be used, but at least if at all you have to remember any one value, please remember the AIMS values. Then another important aspect is, how do you diagnose overt diabetes? How do you diagnose overt diabetes? If in a pregnant woman, if in the first ANC visit, for whichever reason you have done the glucose tolerance testing, let's say 75 grams OGTT has been done in the first ANC visit. Like for example, let's talk about a woman who is 40-year-old and she's pregnant, and if she has had a history of GDM in prior pregnancy, she's also obese. So all these are risk factors where I would like to test this woman in the first trimester itself. And let's suppose if I have tested her in the first ANC visit, that means in the first trimester itself, and if any have come positive, what are these any that could come positive? There are 3 things that could come positive. One is that the fasting plasma glucose is more than equal to 126 milligram per deciliter. All right. Alright, if the fasting is more than 126 milligram per deciliter, then the diagnosis is overt diabetic. If the HbA1c is more than 6.5%, or the random blood plasma glucose is more than 200 milligram per deciliter plus there are symptoms pertaining to diabetes. All right. So if in the first ANC visit the fasting plasma glucose level comes out to be 126 milligram per deciliter, then the woman is diagnosed as having overt diabetes. If the HbA1c comes more than 6.5%, the diagnosis comes as overt diabetes. If the random plasma glucose is more than 200 and along with symptoms of diabetes, the diagnosis is made at overt diabetes, but this should be there if present in the first ANC visit. Now, how do we manage the diabetes? Once we have diagnosed that this woman is GDM, how do we management of diabetes? Very important, just remember this management of diabetes mellitus in pregnancy. Remember that if it is GDM, if it is gestational diabetes mellitus, then you have to start with diet therapy plus exercise therapy, and this should continue for about 1 to 2 weeks. This should continue, and then she comes back with a repeat sugar profile. In this sugar profile, ideally we take 7 samples, in the sense that she comes back with a fasting value, with a 1 hour post meal value, and with a 2 hour post meal value, and ideally it should be done after breakfast, after lunch, after dinner. So 6 values post meals and fasting value. She comes back with this repeat sugar profile after 1 to 2 weeks of diet and exercise therapy, and her fasting, if her fasting is more than 95, if her 1 hour post meal is more than 140, and if 2 hour post meal is more than 120, if this is the scenario, then she is now started on insulin. All right, then you have to start her on insulin, and the insulin that we give is a combination of regular plus NPH. Right now, very important in this, you have to remember that the insulin requirement increases. The insulin requirement increases in pregnancy as gestation progresses. Okay, as gestation progresses, the insulin requirement increases. So we have to considerably, as she moves on from 28 to 30 to 36 weeks, the amount of insulin that is required to maintain euglycemia will increase accordingly. So we should be knowing that fact. Another important thing is that by these values, you should also remember what is the target for control. The target for control is that the fasting is less than 95, the 1 hour post meal is less than or equal to 140, and the 2 hour post meal is less than or equal to 120, and the HbA1c is less than or equal to 6%. If these are the values obtained on repeated sugar profile, that means the diabetes is well controlled. Another important thing is that once she comes after 1 to 2 weeks, this repeat sugar profile is, these are the venous samples. Okay, these are the venous samples, but usually this is to be done in the hospital, but ideally, once the sugar levels are maintained, once the control is achieved, home monitoring is done by the capillary blood glucose levels. Okay, capillary blood glucose levels, home monitoring is good enough once a target control has been achieved. All right. Another important aspect to remember is that if blood sugar is in the overt range, all right, a diagnosis of gestational diabetes mellitus was made, blood sugars were in the overt range, we will start the insulin directly started plus diet plus exercise. All right. So, for example, if a woman underwent, I will give you an example with this. For example, in a woman in whom glucose tolerance test was performed with 75 gram glucose, and her fasting 1 hour, 2 hour values, if they were found to be, let's say they came out to be 100, 160 and 120. Now in these values we can realize that only this fasting is deranged, all right. So there's one value abnormal, but all these values are in the are not in the overt range as of yet. So in such a woman, a diet and exercise regime will be started first. Now if let's say a woman in whom the same test was done, but her fasting value was 130 and her 1 hour post meal was 200 and her 2 hour post meal was 180. Now these are very high values. They are values in the overt range of diabetes. The fasting is more than 126. The values are in the overt range. Then in this woman, we don't start diet and exercise alone. In such a woman, we will start insulin also along with diet and exercise. So this is one differentiating point that I want you to remember with this question, all right, with this flow chart. So remember this flow chart, it helps you remember a lot of important points. One important point is if it is GDM, then you start diet and exercise. If the blood sugars are in the overt range, we start insulin along with diet and exercise. We should remember the values which are the target values for control, beyond which we should start insulin even after diet and exercise has failed. All right, so let us now see question number 70. And then we will see how we will use our flowcharts to answer these questions. Now, a 30-year-old third gravida para 2 obese woman is diagnosed with gestational diabetes at 26 weeks. Her previous 2 pregnancies were uncomplicated. She started on diet modification and exercise. Now 2 weeks tested. Her 2 weeks later, her sugar profile is done. Her fasting is 100. Her 1 hour PP is 160. What is she advised at this time? So we realize that the fasting here is more than 95. We see that the 1 hour PP is more than 140. 2 hours is not given. Nonetheless, we have 2 values which are abnormal. At this point in time, she is advised to start insulin. All right, at this time she is advised to start insulin. Obviously she will continue her diet modification, that will be continuing. She would start metformin as long as let me give you just a brief about metformin and diabetes in pregnancy. You have to remember that a lot of women who are previously diabetic, known diabetics, will probably be already on metformin. All right, then those women can continue metformin in pregnancy. So just a few important points, that metformin actually crosses the placenta, but it does not cause any lactic acidosis. Lactic acidosis is not caused, all right, and in the fetus. So no documented cases of these have been documented, and it is considered safe in pregnancy. So a woman who is already taking metformin, so if she is already taking metformin, example, there can be women who are on PCOS who are taking metformin for insulin sensitization. There can be women who are known type 2 DM who are taking metformin. They can continue to do so. They can continue to do so. They can continue to do so. They can continue to take metformin. Then another drug which has been another drug which has been talked about is glyburide. Now regarding glyburide, the current status is that it is considered safe in pregnancy. However, it is not a first line treatment apart from research setting. So usually this is also not preferred. So the drug of choice for diabetes in pregnancy at present remains insulin only. When you talk about the various forms of insulin, then regular and NPH is the combination that is used as far as insulin is concerned. The Lispro and the Aspart and the Glargine, the short acting and the long acting ones, they are not used in pregnancy. Okay, they are not used in pregnancy. So far we use freely NPH and regular insulin, that is what is used. Now, question number 78, that was what we had to discuss. We will just see question number 78 right now because we are doing diabetes. So, question number 78, see here, a 32-year-old woman with family history of diabetes in both parents tested with OGTT at 8 weeks. So, since she had family history of diabetes, then even at 8 weeks her OGTT was done. Her fasting blood sugar is 100 and her 2-hour value is 180. So there means that she is GDM, she is diagnosed as GDM, right? And we see that her 2-hour value is quite a lot. Her fasting is yet not in the overt range, but to be 8 weeks and with such high values 2 hour post meal, she has not been any treatment in the past. The next step in management is to perform HbA1c. She will ultimately start diet modification, true. Alright, she will ultimately start with diet modification, true, but at this point in time performing HbA1c is important, because so that counseling can be done regarding the risk factors of the risk of congenital anomalies, and to know if she is actually overt diabetic, because that will only be found by the HbA1c levels, because if they are more than 6.5%, then we know that periconceptually her control has not been okay and she is a overt diabetic. However, that will only help in counseling the woman regarding the risk of abortion or congenital anomalies in this pregnancy. It will not change the management because the sugars are not in the overt range as of yet. So she will start her treatment with diet modification first. Alright, so as far as the treatment, starting the treatment is concerned, HbA1c does not really change that management. The starting, whether starting insulin or whether starting with the diet and exercise modification, that is decided by the sugar levels, alright, but that is decided by the sugar levels, not by the HbA1c levels. Knowing the HbA1c levels helps in counseling the woman regarding the risk of abortions or congenital anomalies, alright. So this performing HbA1c can help in counseling the woman. However, treatment will not be deferred. And now moving on to question number 79. Okay, not 79, sorry, we skipped. We have to come to question number 71. Now identify the instrument given in this image here. This is a vaginal wall retractor. Now this is a vaginal wall retractor. It looks something like a curette, but it is bigger here, and this is hollow. This is bigger here, and there are serrations. So this end here, this is bigger and there are serrations. Alright, if I were to show you a curette would be like this, something like this. It again will be hollow like this instrument, but then there will be no serrations, okay. So in a curette the difference is no serrations in curette, right. Whereas in vaginal wall retractor, the end of this end, the terminal ends of the instrument are going to have these serrations. So that is how we would differentiate between a curette and a vaginal wall retractor. Now moving on to the next question, question number 72. Regarding vaginal candidiasis, which one of the following is false? The answer to this is C. Alright, now cottage cheese like secretions, I told you, cheesy, curdy, white secretions, they are there. Intense pruritus is there, this is present, this is also present. Buds and hyphae in KOH preparation, this is also present. It is most common in non-pregnant women. Basically, you have to remember that vaginal candidiasis is particularly very common in pregnancy as far as versus non-pregnant women. So vaginal candidiasis is more commonly seen, in pregnant women versus non-pregnant women, alright. Because in pregnancy it is like an immune modulated state, and that is why vaginal candidiasis, a pregnant woman is more prone to develop vaginal candidiasis. Now next question, question number 73. Highest rate of ectopic pregnancy is seen with, among all of these options, the correct option is option number A, progesterone. However, if you talk about the language of the question, this language is slightly incorrect. I would like to change it a little here. Highest rate of ectopic pregnancy. We all know that all contraceptives actually decrease the absolute risk of ectopic pregnancy, all right. Be it Mirena, be it progesterone is no longer used, so I do not think any new question will have this option as progesterone. It is neither available nor it is used anyways. We have Mirena now in place of the hormone containing IUCD. So all contraceptives decrease the absolute risk of ectopic pregnancy, be it copper T, be it OC pills, be it progesterone only pills or whatever. But it is the failure of contraception, whenever a contraceptive method fails, there is risk of ectopic. Now this risk of ectopic is highest. This risk of ectopic is highest with sterilization failure. Okay. After sterilization, there is Mirena. After Mirena, there is copper T, 380A, then POPs, and then OCPs. All right. So you should remember that the risk of ectopic pregnancy is more with failure of contraception, and it is maximum whenever the sterilization failure, and it is least with OCPs. When you compare Mirena versus copper T, the risk of having an ectopic pregnancy is more with Mirena failure as compared to copper T failure. So we remember that the maximum risk is with sterilization failure, least is with OCPs, and compared with Mirena and copper T 380A, the risk is more with Mirena failure than with copper T failure. So these are the salient points which you should remember here. And now we can move on to the next question. All right, now specific treatment of severe preeclampsia is, and the answer is 74, the answer is B, termination of pregnancy. All right, now for the next part of the discussion here, I want to talk about a very, very, very important topic as far as your exams are concerned, which is hypertension, hypertensive disorders in pregnancy, including gestational, chronic, and preeclampsia. Almost all aspects of this topic have been asked time and again. All right. So now my discussion, there are 4-5 questions about preeclampsia in this test series. I want to discuss all of them together here so that we get a clear understanding of the topic. We have question number 74. The discussion will include question number 132, question number 138, question number 172, and question number 177. Just note down that these are the questions we are going to discuss, and we are talking about hypertensive disorders in pregnancy. Now when we are talking about hypertensive disorders in pregnancy, I want you to remember the first very basic concept we have to remember is that the different types of hypertensive disorders, because questions can be straight away asked on the clinical scenario and ask you to identify what kind of hypertension is it. Is it gestational, is it chronic, or is it preeclampsia? So one thing, very important thing here, let's say that let me just start fresh here. Let me start fresh here. Let's say that a woman is pregnant here, and then she, let's say, delivers here, and this period is 12 weeks postpartum. So these are the 3 milestones, and this is 20 weeks. This is another milestone here. And we know that usually in pregnancy, when we discuss the maternal adaptation, we discussed that the BP falls in the first half of pregnancy. The nadir of BP reaches at around 24 to 26 weeks. That is the usual change in pregnancy, that BP falls. So we see that any hypertension that has to develop in pregnancy usually manifests in the second trimester, sorry, in the third trimester beyond 20 weeks, beyond 24 weeks. So usually it is said that any hypertension which is diagnosed in the beyond 20 weeks, and then that hypertension comes back to normal within 12 weeks postpartum, right? So BP more than 140 equal to more than or equal to 140 by 90 mmHg beyond 20 weeks, but it comes back to normal within 12 weeks postpartum, right? And there is proteinuria is absent, then this hypertension is gestational hypertension. Alright. Now another very important aspect I want to specify here is that sometimes, a woman can be chronically hypertensive also. Who will be a chronic hypertensive woman? A chronic hypertensive would be somebody who is hypertensive even before pregnancy, or is found to be hypertensive in the first 20 weeks of pregnancy. This would be chronic hypertension. So hypertension, pre-pregnancy hypertension, alright, or hypertension in the first 20 weeks of pregnancy, before 20 weeks of pregnancy, that would be chronic hypertensive, right? Sometimes, there can be a woman with chronic hypertensive whom we do not know that she has had high BP pre-pregnancy, alright, and maybe she is coming in the first trimester. Then her BP is not high in the first trimester. Why? Because in pregnancy, in the first half, BP normally falls, alright. So such chronic hypertensives can be missed in the first 20 weeks of pregnancy. Then such chronic hypertensives will be diagnosed beyond 20 weeks. Those chronic hypertensives in which BP remained normal because of the usual fall in BP in the first half of pregnancy, such chronic hypertensives can resurface at 20 weeks. But there is no way of knowing for sure whether it is chronic or gestational hypertension. Then such hypertension at that point in time shall be labeled as gestational hypertension, but the difference with gestational hypertension will be that gestational hypertension would have come back to normal 12 weeks postpartum, but this hypertension continues to persist even after 12 weeks postpartum. Then such is also chronic hypertension. That means maybe it was diagnosed high BP beyond 20 weeks, but then it never became normal, but it not became normal after 12 weeks postpartum. Then it is chronic hypertension, alright. So these are the basic differences between gestational hypertension and chronic hypertension, right. Now what is preeclampsia? Now out of these gestational hypertensive women, 50% of these can progress to preeclampsia. Now what is preeclampsia? Preeclampsia is BP again more than 140 by 90, plus either there is proteinuria or there are end organ changes. Okay, either there is proteinuria or there are end organ changes. To say proteinuria, what is proteinuria? Proteinuria is more than 300 milligram protein in urine per 24 hours, or it is more than or 1 plus in dipstick, or it is urine protein to creatinine ratio more than or equal to 0.3. This is proteinuria. But proteinuria is not essential any longer to make the diagnosis of preeclampsia. Preeclampsia can be diagnosed even with end organ changes. And what are those end organ changes? Those end organ changes are Very, very important, any of these end organ changes, if present, they make the diagnosis of preeclampsia. Those end organ changes are decreased platelet count to less than 1 lakh per mm cube, increase ALT and AST more than 2 times normal, serum creatinine more than 1.1 milligram per deciliter. All right, then there is impending signs and symptoms, right, like epigastric pain, headache, blurring of vision. All these are impending signs and symptoms. These are the end organ changes that can happen: headache, blurring of vision. All right, these are impending signs and symptoms if they start coming. So we have to understand that preeclampsia is this. Another very important point that you have to remember is what is severe preeclampsia. What is severe preeclampsia? So preeclampsia, severe preeclampsia is BP more than or equal to 160 by 110 or any of the end organ features. Okay, any of the end organ features means severe preeclampsia. What is no longer included in making the diagnosis of severe preeclampsia, no longer included in the diagnosis of severe preeclampsia is proteinuria, degree of proteinuria, the degree of proteinuria, IUGR and oligo. So important point to remember that these three are no longer included in making the diagnosis of severe preeclampsia. All right. So one thing we have understood, what are the various types of hypertensions in pregnancy. Second thing you have to remember, what is chronic hypertension plus superimposed preeclampsia. Chronic hypertension plus superimposed preeclampsia is any woman with chronic hypertension now with new onset proteinuria more than 20 weeks. All right. So you have to understand that any woman who is found to be chronic hypertensive before pregnancy or chronic hypertensive who's trying to conceive or who's been seen in the first trimester, a baseline workup of her hypertensive status is made. That means it is seen whether she have hypertensive retinopathy, whether she already has pre-existing liver dysfunction, if she has a pre-existing proteinuria or nephropathy. So all that has to be documented at a baseline. If we know the baseline, then only we can say whether she is now having new onset proteinuria beyond 20 weeks or there is an uncontrolled BP beyond 20 weeks or end organ damage which was previously not there but now it is appearing beyond 20 weeks. That would mean that she is now becoming superimposed preeclampsia along with chronic hypertension. All right, so this is about the definitions. Other important aspects about preeclampsia you should understand are what is the pathophysiology of preeclampsia. Now I just want to give you the salient points about the pathophysiology of preeclampsia, and I want to discuss here that the culprit of this preeclampsia is the placenta. To be more precise, a more precise answer would be chorionic villi, because even without proper placenta and fetus, like in molar pregnancy, preeclampsia can happen even without a proper placenta and a fetus. So it is actually the chorionic villi so chorionic villi is a better answer. It is actually the chorionic villi or placenta which is the culprit in case of preeclampsia. So the definitive treatment is always delivery. Delivery of the fetus, delivery of the placenta, delivery of the chorionic villi. The definitive treatment is termination of pregnancy. The definitive treatment is delivery. All right. Now, what happens at the level of these chorionic villi? You have to remember that in pathophysiology of preeclampsia, what is happening is there is incomplete trophoblast invasion. There is incomplete trophoblast invasion of spiral arterioles. All right. When we talked about the placenta, we discussed that the spiral arterioles are invaded by the endovascular cytotrophoblast, and this makes the spiral arterioles lose dilated channels which can transmit, which allow for the increase in uteroplacental circulation. But now that is not happening. There is incomplete trophoblast invasion, and there is no placental bed remodeling. When there is no placental bed remodeling, there is placental ischemia because these vessels remain narrow, and that leads to release of inflammatory mediators, and these inflammatory mediators, they lead to endothelial damage. This is the centerpiece of the pathology. There is endothelial damage. This is the centerpiece of the pathology, that is the endothelial damage. This endothelial damage happens at the placental bed. This happens in placental bed, and this happens everywhere in the maternal circulation and in maternal circulation as well, because these inflammatory mediators, they seep into the maternal circulation. Now this endothelial damage leads to a lot of other things, like this endothelial damage leads to vasospasm and thrombotic sequelae, vasospasm and ischemic sequelae. This leads to thrombotic sequelae, and this leads to leaky capillaries. This endothelial damage leads to leaky capillaries, right? So these are the usual pathophysiological events that can happen. Now this vasospasm, this ischemic sequelae, they cause hypertension as one. They can cause hepatic necrosis. Because they cause hepatic necrosis and dysfunction, there is increased enzymes. There is epigastric pain. This epigastric pain develops because of the stretching of the Glisson's capsule. Stretching of the Glisson's capsule. There is retinal ischemia, which will lead to visual disturbances. There is cerebral ischemia, which happens, right? Then thrombotic sequelae leads to platelet consumption, leads to decreased platelet count. Thrombotic sequelae, also lead to DIC. In severe cases, there can be DIC. What happens because of leaky capillaries? Because of leaky capillaries, there is hemoconcentration is one change that happens, right? And fluid moves out in the interstitial spaces, right, from intravascular to the extravascular compartment, and that leads to edema everywhere, right? Then that also leads to pulmonary edema, that also leads to cerebral edema, that also leads to glomerular endotheliosis. So these are the basic changes. At least you should remember this very, very important flow chart I am giving you. You should remember that there is epigastric pain is a manifestation of severe preeclampsia. There can be retinal cerebral ischemia. There is decreased platelet count. Remember, there is hemoconcentration in preeclampsia. Remember, there can be pulmonary edema, cerebral edema. And remember that there can be the major pathology that happens in the kidneys is glomerular endotheliosis. Because of this glomerular endotheliosis, there is also increased serum creatinine. There is increased serum creatinine. All right. So remember, these are the important points about the pathophysiology of preeclampsia. Now, what happens in case of what is eclampsia? Now, in eclampsia, eclampsia is preeclampsia plus seizures, right? And why do eclampsia happens? What is the theory of the origin of eclampsia? The theory is a combination of edema and edema and the vasoconstriction and everything. So basically the theory is theory of vasogenic edema. You should remember that it is a theory of vasogenic edema because it has been seen. Why this theory of vasogenic edema was given? Because you have to remember that sometimes, eclampsia happened even in the absence of even in the absence of proteinuria. So 10% cases of eclampsia had no proteinuria. right? And around 10% cases of eclampsia, they happen to women with normal BP, right? So they said that there should be another theory which is now accepted as the theory of vasogenic edema. So what happens is that there is loss of cerebral autoregulation, right? And that leads to cerebral hyperperfusion, right? Hyperperfusion, and that hyperperfusion forces the fluid out into the extravascular compartment, leads to vasogenic edema because of increased hydrostatic pressure. And that vasogenic edema, and there are areas of decreased perfusion also because some amount of vasoconstriction and ischemic changes. Ultimately, all of this leads to cerebral hypoxia, and this cerebral hypoxia leads to seizures. Now, this is what the pathophysiology of eclampsia is, and it is the cerebral hyperperfusion which is responsible for headache and which is responsible for scotoma and blurring of vision that is seen with eclampsia. So we realize that this cerebral hyperperfusion, this vasogenic edema, it can involve the occipital lobe. Mostly it has a predilection for the occipital lobe. That is why symptoms of headache and scotoma come, but they can involve the entire cerebrum also. So the presentation of a woman can range from just being drowsy to delirious to comatose, depending upon how much of the cerebrum has been involved in the process of cerebral edema. So if you have to understand, sometimes they ask this question on the type of blindness that is associated with preeclampsia. So remember that if we can talk about blindness associated with preeclampsia, the most common type is the occipital blindness, which is because of the occipital lobe edema, and that is called as amaurosis. This is reversible. Then we have the cerebral infarctions. We can have cerebral infarctions, or we can have the retinal ischemia, and we can have the retinal detachment, and that can lead to, that is called as Pershner's retinopathy. So these are certain important one-liner points that you should remember about the various types of blindness. Blindness most of the times is reversible when it happens because of occipital edema and everything. So this is about the pathophysiology of preeclampsia. Now coming to the other very important factor that you should understand, that preeclampsia is mainly seen in primigravidas. It is seen in extremes of age. It is seen with mainly seen in primigravidas with extremes of age. So there is no way of knowing which young primigravidas will develop preeclampsia, but we can identify risk factors for preeclampsia in multiparous women, right? We can identify risk factors for preeclampsia in multiparous women. One of the very important risk factors would be history of prior preeclampsia or gestational hypertension. So if there is history of prior preeclampsia or gestational hypertension, if there are other high risk factors like primigravida, extremes of age, twins and molar, these are the other high risk factor, right? Chronic kidney disease, chronic hypertension, APLA. So these are the other high risk factors. So ultimately we should understand that to know about the risk of preeclampsia in a current pregnancy, the one and very important factor which helps us to delineate that risk is the risk factors, alright. So as far as screening for preeclampsia is concerned, there is no screening for preeclampsia. We have no screening for preeclampsia. There is absolutely no screening test, no test which has any reliable predictive value, not even uterine artery Doppler notching. However, it has been suggested as one, but then it is not considered a risk, but then it is not considered a good enough test for positive predictive value as far as positive predictive value is concerned. So there is no screening for preeclampsia, but there can be Predictors of preeclampsia. Predictors of preeclampsia, among those, one that is usually talked about is uterine artery Doppler notching, and persistence of this notching beyond 22 to 24 weeks. Persistent notching beyond 22 to 24 weeks was predictive of preeclampsia. However, its predictive value is not very good. Its predictive value is not very good. Neither its positive predictive value nor its negative predictive value. Therefore, it is not used as a method of screening test. Then there are certain new predictors. Very, very important potential question. What are the new predictors which are being investigated? Please remember these. There is increased VEGF and there is increased placental growth factor. These are the angiogenic factors which are involved in placental invasion, which favor the invasiveness of the trophoblast, right? Invasiveness of the trophoblasts, thus favoring endovascular invasion. So therefore, just a little bit of correction. Whenever these factors are decreased, whenever these angiogenic factors are decreased, they will impair the invasiveness of the trophoblast and lead to the development of preeclampsia. So decrease in vascular endothelial growth factor and placental growth factor, and the other factors which are new predictors on the line are increased FLT1 and increased soluble endoglin. This is SFLT1, which is soluble FMS like tyrosine kinase, and soluble endoglin. These are the anti-angiogenic factors, right? So when anti-angiogenic factors are increased, they impair the trophoblastic invasion and thus promote the development of preeclampsia. So these are the new factors which are being studied. Please remember the names of these new predictors. It is a potential question which we are expecting can come. So, but these new predictors are still investigational. A lot of them, they have not come in routine clinical practice. Anyhow, you should also remember that whenever there are high risk factors in history, that woman can be given aspirin from 12 weeks onwards, and the dose that is prescribed is 81 milligrams. Such tablet is not available, so 75 milligrams is also correct, because usually 81 milligram tablet is not there, but this is called as low dose aspirin from 12 weeks onwards, to be continued throughout pregnancy, can be given for prevention of preeclampsia. So when we talk about prevention of preeclampsia, we just have one drug, which is aspirin. Remember that there is no role of anything else. There is no role of salt restriction. There is no role of antioxidants. There is no role of vitamin D or E or omega acids or any of these things. There is no role of calcium supplementation unless documented calcium deficient women. Other than that, there is no role of routine calcium supplementation or any of these supplementations. The only positive role is seen with low dose aspirin. Alright, now moving on to the management of preeclampsia, I want to give you one flow chart to help you answer the clinical based questions as far as management of preeclampsia is concerned. Now, we understood the pathophysiology, we understood that preeclampsia, the culprit is the placenta, culprit is the chorionic villi, so treatment is termination. The only question is when. So we see that the definitive treatment is termination of pregnancy. The only question is when. Now, by the time we are mulling over this possibility of termination of pregnancy, in the meanwhile, what we are doing is we are monitoring the pregnant woman, and we are monitoring what? We are monitoring for end organ changes. So, right, because anytime end organ changes come or anytime they start worsening, the treatment has to change. Then we are controlling the BP on the other hand, and on the other hand we are monitoring the fetus. Now very importantly, you have to understand that in controlling the BP, we are not making controlling BP to decrease the risk of eclampsia. So controlling BP does not eliminate eclampsia risk, okay, very important. And controlling BP on the other hand does what? It prevents the acute hypertensive complications which can happen. All right, they control the acute hypertensive complications which can happen. That is why we are wanting to control the BP. All right, now just a nutshell to understand what are we doing to control the BP. To control the BP, remember that we have two ways. We're talking about two things when you're talking about control of BP. We're talking about acute crisis, control during acute crisis, and we're talking about a normal oral treatment to control the day-to-day control of BP, right? So when we talk about oral treatment and day-to-day control, remember our drug of choice is labetalol, be it any kind of hypertension, chronic, be it chronic hypertension, be it gestational, be it preeclampsia, it is labetalol. But if they specifically ask you which is the safest, then the answer is methyl dopa, right? Methyl dopa is the safest, but our drug of choice is labetalol. Now another important drug is, so one drug is labetalol, one drug is methyl dopa, then we can use nifedipine, which is calcium channel blocker. And remember that nifedipine is never given sublingually, otherwise it will cause dangerous hypertension and lead to sudden impairment of blood flow across the placenta to the fetus, right? So another important point of question that is asked is, when do we initiate this antihypertensive therapy? Then we start this antihypertensive treatment whenever the BP is more than or equal to 150 by 100 mm of Hg, right? And the goal of control is systolic between 130 140 and diastolic between 80 to 90. We do not want the BP to fall less than 130 by 80 again, otherwise it will impair the placental perfusion. Now for the acute crisis, we have the drug of choice again for the acute is IV labetalol. Okay, other than this we can give drugs like nitroprusside, we have IV hydralazine, we have nitroglycerine. All these drugs are there which can be used, but remember that we never give diuretics. We never give diuretics unless there is pulmonary edema. Only in the face of pulmonary edema is diuretics given, otherwise diuretics are contraindicated in preeclampsia because they will further lead to hemoconcentration and loss of intravascular volume, precipitate acute renal failure in such women. So never diuretics unless for the treatment of pulmonary edema, otherwise diuretics are absolutely not given. Very important point to remember. Alright. Now we also have to understand, now coming back to this flow chart here, that definitive treatment is termination of pregnancy. So we were doing all this, we were monitoring the fetus for its well-being, we were controlling the BP, and we were monitoring for the end organ changes, alright. So if everything remains okay, like for example if it is mild preeclampsia or gestational hypertension or chronic hypertension and the BP is controlled on drugs or without drugs, there is no end organ changes are coming, proteinuria irrespective of proteinuria, but mainly important factor is everything seems okay. The termination of pregnancy at 37 completed weeks, okay? Termination of pregnancy at 37 completed weeks. So a woman with preeclampsia, mild or gestational hypertension has happened to cross 37 weeks with BP control and everything, there is no point in prolonging the pregnancy any further. We have to terminate at 37 completed weeks. Question is, Whenever she has severe preeclampsia, problem is with severe preeclampsia. Whenever she has severe preeclampsia, that is BP more than 160 by 100 or any of the end organ changes, right? What do? We have to immediately, first of all, the step is to hospitalize, stabilize. Stabilize means control BP. Stabilize means give steroids if less than 34 weeks of gestation, and stabilize means plus minus magnesium sulfate. Especially if we are deciding on termination, then we start the, especially termination if planned, then we start with magnesium sulfate, then we have to give. So first step is hospitalize, stabilize, steroids, and consider whether magnesium sulfate is required or no. This is the basic step, and then we have to decide. We see that if it is more than 34 weeks with severe preeclampsia, more than 34 weeks, we terminate. Termination of pregnancy is the answer. Alright, so deliver, we have to achieve delivery. This delivery has to be by induction of labor, be it term or preterm. There is no indication of any direct cesarean section in this case. If she is less than 34 weeks, if she is less than 34 weeks, we try this conservative management and we see if everything settles down okay. But we will terminate, we will try to settle the condition, right? Try to settle the condition, and maybe at least take care of at least by 2 days, at least 48 hours, for at least 48 hours till steroids act. Right now we have started this conservative management at less than 34 weeks, but at any point of time the woman is worsening or her status is worsening, then we give up this conservative management in favor of delivery, right? So mother will always take precedence. So you have to remember the indications for termination irrespective of period of gestation. So the indications of terminations irrespective of period of gestation becomes BP uncontrolled. So we tried to control BP at less than 34 weeks, but it is not controlling. We have used all the drugs possible and it is not getting controlled. There is rising serum creatinine. There is worsening of BP, there is pulmonary edema, there is HELP syndrome, or there is impending eclampsia, or there is eclampsia. Now these are indications of terminations irrespective of period of gestation. Another important factor is if it is a pre-viable fetus. Pre-viable fetus means less than 24 weeks, then also we will terminate irrespective of the period of gestation. Then such a fetus should also be terminated. Terminate the pregnancy in such a situation. There are other 3 indications of termination irrespective of period of gestation, which are fetal indications. One is fetal distress, the other is abruption, placental abruption, and the other is reversed end diastolic flow on Doppler. So these are 3 other indications of termination of pregnancy irrespective of the period of gestation. Now this much is the basic 3-4 flowcharts that I've given you that you should remember when answering questions about preeclampsia. Alright, now let us see one by one how we can use our flowcharts here that we have discussed to answer the respective questions. Let us see question number 74 here. So we realize that the specific treatment of severe preeclampsia is anyways termination of pregnancy, but you have to know in severe preeclampsia we always terminate if the woman is more than 34 weeks. If she is less than 34 weeks, we start with stabilizing steroids, controlling BP and everything else, and if then situation worsens, then we terminate. So question number 132. Let us see question number 132. Right. Question number 132. A second gravida para-1 live 1 lady with previous cesarean comes at 37 weeks with BP 150/100. CTG's reactive PV findings are os closed, partially phased cervix, soft, midline, vertex -2, pelvis is adequate. Urine protein is by dipstick is 1 positive. So basically we have made the diagnosis of preeclampsia. We have made the diagnosis that she is beyond 37 weeks of pregnancy. Her BP is fine, she is 150/100. Nonetheless, she is mild preeclampsia, no other impending signs and symptoms are there. So the answer is terminate. Terminate is the answer, but the difference is whether we terminate by induction or cesarean, because what is the confusion? The confusion here is previous cesarean. Now previous cesarean by itself is not a contraindication for, is not an indication for a repeat cesarean section in such a situation. So even though terminate, it has to be by induction. Even though she has previous cesarean, her cervical findings are fine, os is closed but the cervix is partially phased, midline, soft. So the pelvis findings, the Bishop score is also fine, not that ominous or unfavorable. So the answer is terminate and the answer is induction of labor. So 132, the correct answer is option number B. Question number 138. A female with 35 weeks presents an emergency with complaint of headache and blurring of vision. Her BP is 170/110. Now she is 35 and she is severe preeclampsia. She is 35 weeks and she is severe preeclampsia. We can see, and headache and blurring of vision is putting her in impending eclampsia. Right, on top of that, impending eclampsia, right? So the answer is to admit, to control her BP because she needs antihypertensives also, and to terminate the pregnancy. So the correct answer of question number 138 here in this case is option number C. Admit, start magnesium sulfate and antihypertensive and terminate the pregnancy. So let me just here summarize for you people what are the indications of giving magnesium sulfate. What are the indications of giving magnesium sulfate? All right. Now magnesium sulfate is always given with eclampsia. Now when it is given with eclampsia, it is basically, remember that magnesium sulfate is not an anti-seizure medication. It is not an antihypertensive medication, but it is given for neuroprophylaxis. That means it basically, when you give in eclampsia, it prevents further seizures. Okay, it prevents further seizures, right? Therefore, the logic of giving magnesium sulfate even before the actual eclampsia or before the actual seizures develop, that is called as prophylactic magnesium sulfate. That means we give magnesium sulfate even before seizures have happened, and we give it when we are suspecting that seizures can happen at any point in time. So those conditions are impending eclampsia, severe preeclampsia, especially if we are terminating a woman with severe preeclampsia. Obviously we are terminating. So impending eclampsia, severe preeclampsia and HELP syndrome, these are other indications of giving magnesium sulfate. Therefore in this question, apart from BP control, apart from termination, magnesium sulfate will also be started, because this woman is now becoming that of, this woman is now impending eclampsia because of the symptoms of headache and blurring of vision. She is now impending eclampsia. Therefore in this question the answer is option number C. Now question number 172. Let us see question number 172 here. Now, a 25-year-old nulliparous woman, 30 weeks, is admitted to the labor room with a BP of 160/110, urine albumin 1+, so she is preeclampsia, and she is severe preeclampsia by definition because she is now BP 160 by 110. There is no complaint of headache, blurring vision, epigastric pain or decreased urine output. So at least we know that she is not impending eclampsia. NST is reactive. Further management includes all except. So she's 30 weeks. We need at least some time. We need to buy time for steroids to act. So we will not jump onto an immediate cesarean section straight away, right? So we will start the antihypertensive treatment to control the BP here. We will send the baseline investigation to see if there is any end organ damage, because this question does not tell us about any end organ damage. We will give steroid administration and we will consider magnesium sulfate. All right, because she is severe preeclampsia. So all these statements are true except for the fact that we will not immediately jump onto a cesarean section, right? So we admitted this woman, stabilized, BP controlled, give steroids, saw the baseline CBC, LFT, KFT, how they are. If the woman, if the BP comes down, if the derangement in the CBC, LFT, KFT is not there or maybe there and it is in the mild range, we can try to just gain 48 hours for the steroids to act at least, and then terminate, and deciding upon termination after that. Now if after admission and everything the situation becomes that she starts having complaint of headache, blurring of vision, that means she starts becoming impending eclampsia, or during conservative management her CBC, LFT, KFT come out to be grossly deranged and then they are worsening in another 12 hours, then we make a call about terminating the conservative management and delivering the baby. Now question number 177, false regarding new onset hypertension in pregnancy. The degree of proteinuria does not determine severity. This is true. Almost half of the women with gestational hypertension subsequently develop preeclampsia. This is also true. 10% eclamptic seizures develop before overt proteinuria can be detected. This is also true. I told you an antihypertensive treatment is started once proteinuria is developed. This is false. Antihypertensive is started when the BP is beyond 150 by 100. Proteinuria or no proteinuria has got nothing to do with it. All right. Now let us move on to the next question here. Where we left the discussion, which question we were doing? We were doing here. We were here in this question number 75. Complete or incomplete uterine inversion depends on whether fundus has passed through. The correct answer is cervix. All right. So complete inversion is when the uterus has come out beyond the cervix. All right, with os open. So that will be complete inversion. Otherwise, it will be an incomplete inversion. Now, some important points about uterine inversion I want you to remember. What are the important points about uterine inversion? That very importantly, just remember what is the most common cause. The most common cause of uterine inversion is mainly iatrogenic. What do you mean by iatrogenic? I mean by iatrogenic is mismanagement of third stage. By mismanagement of third stage, I mean that cord traction is applied without placental separation and in a relaxed uterus. Without placental separation and in a relaxed uterus. That is what I mean by mismanagement of third stage. So that is the most common cause. Second is atonic uterus. Atonic uterus. And the third is the morbidly adherent placenta. These are the causes of uterine inversion. All right, morbidly adherent placenta, sometimes we apply traction on the placenta which is morbidly adhered, and that leads to uterine inversion. Now initially, whenever the uterine inversion occurs, there is neurogenic shock. But this neurogenic shock does not lead to death. It is basically because of the vasovagal that happens, that accompanies the process of uterine inversion. But the cause of death and mortality and morbidity with uterine inversion is actually hemorrhagic shock, because the uterus which inverts can now no longer contract, right? So obviously hemorrhagic shock is the cause of death. So initially there is neurogenic shock, but the cause of death is hemorrhagic shock. Remember that. And remember these surgeries. I will not go into the detail of these surgeries, but I want you to remember what are the surgeries for uterine inversion. So for acute inversion, there are options where we can go for the vaginal route. Acute inversion, we can go for the vaginal route of procedures. We have the manual reposition by Johnson's method, manual reposition by the Johnson's method, and we have the O'Sullivan's hydrostatic method which can be used. And at least remember that in chronic cases, in cases of chronic inversion, we cannot go by the vaginal route, or where there is incomplete inversion, like for example when there is incomplete inversion, we cannot go by the vaginal route. We have the abdominal route which you resort to, and two surgeries you should remember. One is the Halton surgery and one is the Huntington surgery. At least remember that these are the surgeries which are done for uterine inversion. This is an important point to remember, which are the surgeries. Moving on to the next question, question number 76 we have already discussed. Question number 77 has already been discussed, so we will move ahead. We have question number 78 has already been discussed. Question number 79. Now let's talk about here question number 79. IUI is indicated for all except, the answer here is IUI is indicated for all except tubal factors. What is IUI? IUI is intrauterine insemination. Now see, it is very clear. IUI is intrauterine insemination. I want to discuss here with you the various indications for IUI versus IVF versus ICSI. Alright, now IUI is intrauterine insemination, where important point to remember is IUI is not an ART method. ART, artificial reproductive technique. Alright, now what is ART? ART is any situation. What is ART? Now I want to specify here that ART is any situation where ova is manipulated outside the body. Okay, ova is manipulated outside the body, that is IUI. Sorry, that is ART. So in IVF, eggs are taken out. In ICSI, eggs are taken out. In GIFT and ZIFT procedures, eggs are taken out. But in IUI, on the other hand, the eggs are not taken out of the female body and manipulated inside a petri dish. So IUI is not an ART, remember. In IUI, we are just bypassing the uterus and keeping the sperms inside the uterine cavity. Alright, so very importantly, the tubes have to be patent. The tubes have to be patent for IUI. On the other hand, in IVF, we are mainly doing it to, IVF was originally introduced to bypass the tubes. So mainly in tubal factor infertility, we are doing IUI. But for, we are doing for tubal factor infertility, we are doing IVF. But for IUI, you should remember that the tubes should be patent. Then what are the other indications for IUI? Indications for IUI can be cervical factor, because we are bypassing the cervix. Unexplained infertility, whenever there is unexplained infertility, the treatment begins with ovulation induction plus IUI, not ovulation induction alone. Whenever there is sexual dysfunction, whenever there is the act of coitus, the act of intercourse needs to be bypassed, like sexual dysfunction or severe hypospadias, right? And mild male factor infertility, mild male factor, then these IUIs, they are a good option. And obviously, whenever there is failure of ovulation induction, the next step is to, next step is if the tubes are patent, then we move on to ovulation induction plus IUI. IVF, on the other hand, we should understand that IVF has been done in tubal factor infertility and also in male factor infertility. Also, whenever there is any treatment failure with IUI, then there is IVF with surrogacy, there is IVF with donor oocytes, there is IVF with PIGD, like I told you. So these are various other indications of IVF. Now IVF and versus ICSI. What is the difference between IVF versus ICSI? ICSI is intracytoplasmic sperm injection. In IVF, what we do is we just bypass the tubal factor, right? What we do is keep the eggs in a petri dish along with the sperms, and the sperms have to fertilizes the egg on the own. In ICSI, what we are doing on the other hand, intracytoplasmic sperm injection. One single sperm is manually injected into the egg, right? So the injection has been done, but ultimately the fertilization has to be done by the eggs. So ICSI, the indication of ICSI has been usually done in case of severe male factor. Whenever there is severe male factor, or there is failed conventional IVF, then we do then we do ICSI. Now when we talk about severe male factor, what is the severe male factor that we are talking about? Usually they say that there is no as such clear-cut indication as to what is the degree of severity, but it is universally accepted that sperm count less than 5 million per ml, if it is less than 5% progressive motility, and there is less than 4% normal morphology. So usually if these are the semen parameters, then ICSI is preferred over conventional IVF. Alright, so if the sperm count is less than 5 million per ml, that means it is severe oligospermia. If it is less than 5% progressive motility or less than 4% normal morphology, then ICSI is preferred over IVF. Whereas tubal factor infertility has been used for male factor, So mainly this is the difference between the IUI, IVF and ICSI procedures. This much at least you should understand about the indications. And another very important thing about IUI to remember is, about all of these procedures to remember is that always, always the sperm preparation, the sperm is prepared. There is a sperm preparation which is done prior to IUI, right, and prior to IVF also. The sperm preparation is done, and the best way to prepare sperm is by density gradient method, right? Density gradient method. The other method is swim up technique, which is a much more commoner technique. It doesn't require any centrifugation and expensive apparatus, but nonetheless the best is the density gradient. And there is the other, which is the commonly used method, is swim up technique. And you should remember about, very importantly, about the timing of IUI. When is IUI done? Now, IUI has to be done at the time of ovulation, right? So it is done at the day of ovulation. If we are documenting ovulation by whichever method, mainly most commonly this is seen by ultrasound monitoring. So at the day of ovulation, if the trigger for ovulation is given, then IUI is done 36 hours after we have given the trigger, or it is given day after LH surge detection, if LH surge is used to detect ovulation, day after LH surge detection in urine. Alright, so timing of IUI is governed by these two factors. Usually we are using ovulation, then we do it on the day of ovulation. If we are giving trigger, we do IUI 36 hours after the trigger. Very importantly, the best results of IUI, they are obtained if the total motile sperm count is more than 10 million and 14% is the normal morphology. If this is there, this is total motile sperm count is 10 million and more than 14% normal morphology in a prepared final sample. In a prepared final sample, if these are the values of your total motile sperms and total morphology, then IUI has best results. Then the results of IUI are best as the number of motile sperm count, as the number of morphologically normal sperms start decreasing, the success of IUI also starts decreasing. Alright, so this is what is important to remember, that when we decide IUI versus IVF versus ICSI, alright, what you have to remember is there's no clear-cut distinction as to what counts we would offer IUI or what counts we would offer IVF, right? So remember that for mild derangements so remember, for mild derangements of male factor, we prefer IUI, alright. Then in IUI what happens is the chances of IUI are maximum when the motile sperm count is more than 10 million and when the morphology is more than 14% in a processed sample. As the count start falling beyond this, the success of IUI starts decreasing and we start choosing IVF. However, we choose ICSI whenever there is less than 5 million sperms per ml, less than 5% motility and less than 4% morphology, that means severe male factor. So whenever there is severe male factor, we preferably choose ICSI, mild factor we preferably choose IUI, and we move on to IVF if IUI has been unsuccessful, and we move to ICSI when IVF has been unsuccessful. So this is about the IUI versus IVF versus ICSI.